Good afternoon, everybody. Thank you for joining in today's session, and which is going to be on fluid and electrolyte problems or not problems, even how to approach in a child whom you are admitting when you have a fluid, if you're planning to give fluids and electrolytes. So my request to all the participants is first to keep all your phones in the mute position. There is a on your screen there is a button on your microphone, so if you can press that, it will mute everybody, and also you can mute the video of your screens. So thank you. So we'll proceed to the presentation, and if you have any doubts, you can post your doubts on the chat box. So if the chat is there, you'll be able to we'll be able to interact accordingly. So in this presentation, we will be dealing with first we will be seeing the maintenance fluids, which is a very important thing of a maintenance fluid that we routinely use in our practice. Mostly we use in children who they come with poor feeding or something else. So maintenance fluid or post-operative. So maintenance fluid, how to choose and what fluid to choose. The second is we go based upon the commonest electrolyte disturbances, which is the sodium, and then the potassium and calcium disturbances. So we'll be discussing these three disturbances, and predominantly we will be focusing on sodium, which is quite challenging because even some changes in sodium level can lead to catastrophe. Potassium, simultaneously, we all know a lot about potassium disturbances, so I'll be touching 1 or 2 slides on potassium as well as calcium disturbances. So what is a maintenance fluid? The basic definition of maintenance fluid is it should have a certain volume and it should have a certain electrolyte content, and it can be prescribed, and this maintenance fluid should help in maintaining the homeostasis of an individual who is not able to control his or her own intake. And the assumption of the maintenance fluid itself is that the fluid and electrolyte is normal to begin with. So this is a condition which satisfies for children who are post-operative, and also for children who just have a poor feeding or no other organic problem in them. So this is how a maintenance fluid actually is meant for or defined for. And most of our maintenance fluid, including the holiday cigar, is calculated based upon a normal child. But the challenge is most of the children who are completely normal, they might not be requiring maintenance fluid. Even now, people have observed, like even post-operative children, they are operated for some anomaly or some pathology, and eventually their own maintenance fluid is not, they are not in a normal state to begin with, so they do have some abnormality. So before starting or completely following a holiday cigar or that the fluid regimen that we usually follow, we have to assume, like we have to ensure that the fluid and electrolytes is normal to begin with. Obviously, it will take time. Even if you send an electrolyte sample today or you assess the fluid status, it is going to take time for 6 hours. Therefore, we have to follow an approach to decide what kind of maintenance fluid is going to be beneficial for all our children. So in the maintenance fluid, in order to understand what kind of maintenance fluid we have to use, we have to understand the water homeostasis and the electrolyte homeostasis, as well as the nutritional requirement. So the nutrition that we are going to give through the maintenance fluid should only be adequate enough to prevent starvation ketoacidosis and to maintain normoglycemia. We need not aim for complete buildup when we are starting a maintenance IV fluid. That deals with a completely different spectrum, which is a parenteral nutrition. So when you come to a maintenance IV fluid, the glucose that you are giving in a maintenance IV fluid should be adequate enough only to prevent starvation ketoacidosis and to ensure a normal glucose homeostasis. So what are the most commonest regulator of water and sodium homeostasis? That is, there are three hormones, the neuroendocrine system. One is the arginine vasopressin, the renin-angiotensin-aldosterone axis, and the atrial natriuretic peptide. So all these three, they determine the plasma osmolarity. So the regulators of osmolarity are, one is the serum osmolarity, how these hormones they interplay. It depends on the serum osmolarity as well as the effective circulating volume, meaning the effective arterial blood volume. It is not the total extracellular fluid compartment, it deals with the effective circulating volume. So in this, the major role is played by the arginine vasopressin, and the renin-angiotensin-aldosterone and natriuretic peptide, they follow the supportive role. So the most important thing in a water homeostasis is to maintain a normal osmolarity, whereas the sodium determines the amount of the extracellular fluid volume or the effective arterial circulating volume. So the if you talk about osmolarity, then we are dealing mostly osmolar disturbances. We are dealing mostly with the problem on the arginine vasopressin axis. Suppose if you are dealing with sodium disturbances alone, like hypo or hypernatremia, then the renin angiotensin aldosterone axis also has a major play. So this arginine vasopressin axis, as I said, which is a major determinant, it is not only secreted by the hemodynamic stimuli. Usually when an AVP will be secreted from the posterior hypothalamus, posterior pituitary, it is when there is a sense of either increased osmolarity. When there is an increase in osmolarity, the osmoreceptor senses, and that will create a stimulus for secretion of arginine vasopressin. This AVP will act on the kidneys to cause more water, free water reabsorption, thereby to decrease the serum osmolarity. Sometimes the hemodynamic stimuli, meaning the baroreceptors, which is present in the aorta as well as in other regions, they carry afferent impulses depending upon the stretch of the baroreceptors in these regions. So if there is a poor hemodynamic condition, the baroreceptor stretch will be less, and this stretch will be carried by the vagus and the glossopharyngeal nerves, and this will stimulate the arginine vasopressor release. So these are the hemodynamic stimuli. But sometimes the AVP is also released by non-hemodynamic stimuli, and this is what we have to understand. So when there is no hemodynamic stimuli, it doesn't mean AVP is not playing a major role. Even in non-hemodynamic stimuli, like simple conditions like post-pain and stress, which commonly happens in post-operative patients, nausea, vomiting, respiratory disorders like hypoxemia, hypercapnia, hypoglycemia, many medications including opioid, anti-epileptics, antipsychotics, perioperative state, inflammation, cancer, all these conditions, they have a non-hemodynamic stimuli for secretion of AVP, meaning most of our children, they are in a AVP excess state. They are not in a arginine vasopressin deficient state. Therefore, even if you are dealing with a normal postoperative patient, you have to assume that they are in a AVP excess state unless or until proven otherwise with clinical features of dehydration. So in states of sodium and water imbalance, we have two categories. One is, the first important thing is, as I said before, to start a normal maintenance fluid is to estimate the volume status. So how will you estimate the volume status? This is clinical because you have to start the maintenance fluid immediately. So look for low effective arterial blood volume states like history of free water loss, dehydration features on examination, presence of tachycardia. Whenever there is an effective decrease in the circulatory volume, the first response we get is tachycardia. Therefore, presence of tachycardia and absence of edema. So if there is absence of edema, if there is tachycardia, and if there is features of dehydration, we are dealing with a low effective circulatory volume state. And the other possibility is the high or normal volumic state. And here you can detect the presence of edema, or if there is any predisposing condition in the history, the presence of hypertension, and no signs of hypovolemia or no signs of dehydration. This is what you can gather grossly from history and clinical examination at admission. So at admission, classify your patient into low volume or normal or high volume. Then we will be going into the specifics. Suppose if there is a normal or high volume, we are either dealing with a decreased fluid and sodium excretion, which is called as the oligoanuric state. So then look for the urine output. If the urine output is less, then this particular state is called as an oligoanuric state. If the urine output is more, or if the urine output, if there is water loss externally, so there are two more states called as the free water loss states, which is renal, which happens when there is a renal concentrating defect, and extrarenal. Suppose in cases like hyperpyrexia, burns, GI water loss, the most commonest thing, gastroenteritis, you have an extrarenal loss. So either there is a free water loss state, or there is a free water as well as sodium retention state, which is the oligoanuric state. So based upon this, you try to categorize your maintenance IV fluid. So nowadays, the problem of hyponatremia, as I said to you, the arginine vasopressin state, which is most commonly seen in children. Therefore, the current dictum is always begin with isotonic fluid across the states, even in oligoanuric state, in edematous states, in states of AVP excess, in non-hemodynamic AVP excess, CNS disease, as well as in free water loss states. But the volume of fluid that you are going to give, that is going to differ. For example, in the oligoanuric state, you are going to add 5% dextrose with isotonic fluid, but the volume is going to be only 25% of the Holiday-Seeger calculation, or 300 to 400 ml per meter square, which is for the insensible water loss. The replacement of the isotonic fluids to sodium free or the solute free condition depends upon your documentation of acute kidney injury. Suppose if you document that there is an acute renal failure which is established, then you change your fluids to from the isotonic fluids, meaning sodium containing fluids, to a sodium free fluid. Coming to the edematous states, as soon as you see the patient, the child looks edematous, again you start on isotonic solutions, and you give only 40 to 60% of maintenance of the Holiday-Seeger formula. Suppose if you are seeing the patient is non-edematous, but the patient is also not dehydrated, then you are considering a euvolumic state, probably the state of AFP excess, but the stimuli could be non-hemodynamic. So here you start on 5% dextrose with isotonic solution. The maintenance fluid again here would be around 70 to 80%. And if the requirement is more, then you replace it with the urine output. Suppose if your urine output is more than 3 to 4 ml per kg per hour, the excess loss you replace it with urine output. But usually if there is a AVP excess state, you won't have that much high urine output. Coming to the CNS disease, again here the peculiarity is you should not allow hyponatremia, or in fact you have to target sodium levels which is more to decrease cerebral edema. So since the target sodium is more than 140, here you have to consider either an isotonic solution, but you can even start a hypertonic solution if the sodium level or the first sodium level, if you have prior to admission, is low. Suppose if you don't have a sodium level, start with isotonic solution, but this is one state where you are giving 100% of the Holiday-Seeger maintenance. We all know that even CNS disease can cause AVP excess, but initially during the acute phase of a CNS disease, we are more concerned about the effective arterial blood volume, meaning you have to ensure the cerebral circulation, meaning you have to ensure cerebral perfusion. So restricting fluid in such situation without knowing the details can cause a CNS restricted cerebral perfusion, leading to further worsening of cytotoxic cerebral edema. So here you consider giving 100% of the Holiday-Seeger maintenance. And the last thing is free water deficient state. And in this free water deficient state, again here this condition you have to use isotonic fluid immediately, but here the total maintenance is going to be large. You can even consider up to 120% of the maintenance of your 1.2 times the maintenance of the Holiday-Seeger method. So it all depends. The only commonest denominator is always begin with isotonic fluids, but the volume varies depending upon the state that you are encountering with. So how to juggle? Again, it based on the volume status, the plasma osmolarity, as we discussed before. Then coming to the glucose needs, the glucose should only be required as much as it is possible to maintain or to prevent starvation ketoacidosis, and also to maintain normoglycemia. And other electrolyte requirements like potassium and calcium, you have to do it adequately. So why these things are important? This is important to prevent hospital-acquired hyponatremia. And usually it is very common, even though we don't do serum electrolytes very often, but in ICU settings when we do, we find that the hospital-acquired hyponatremia is a very commonest condition, and it has strong association with usage of hypotonic fluid, meaning even N/2 saline or ringer lactate. So the most best fluid to use is the isotonic fluid, and usually this is observed when you give IV fluids for a prolonged duration. So as much as possible, even if you use a hypotonic fluid in situations where you don't have isotonic fluids available, try to bring the patient back to an enteral supplementation as early as possible. Do not keep on giving keep the patient on IV fluid dependent maintenance for more than 48 hours. And these children, they have an increased risk of encephalopathy. And the hyponatremia in ICU setting has been documented by many studies as an independent risk factor for mortality, and therefore prevention is very important. Coming to the isotonic fluid, what do you mean by isotonicity? Isotonicity means the tonicity of the fluid, the osmolarity of the fluid, it should be equal to the tonicity of the plasma, meaning 280 to 219 milliosmoles per liter. The osmolality is different. For example, when you add dextrose to your fluid, the osmolarity increases, but the tonicity, meaning dextrose is freely diffusible across the membrane. Therefore, once you give the fluid into the blood volume, the dextrose diffuses into the membrane. The reason the solutes what maintain the tonicity is your sodium. So the tonicity depends on the sodium. Again, once the fluid goes into the blood circulation, the osmolarity comes down and the tonicity will be equivalent to that of plasma. The tonicity is exclusively dependent on the sodium concentration in states where the blood glucose can be freely diffusible. Similarly, if you take a DKA where there is a problem in diffusion of glucose across the cell membrane, even higher osmolar fluids, they have higher tonicity. So in DKA purposes, you have to start with only 0.9% saline without dextrose. So the most fluid with normal tonicity is the 0.9% NS or a plasma-lite or other fluids. Again, there is another component of your IV fluid, which is the percentage of free water. So usually an isotonic fluid will have zero free water, meaning there won't be any additional electrolyte free water. So out of all the fluids, it is only 0.9% NS which does not have any free water. So if in cases where there is free water excess or free water like the AVP excess states, that is what we are talking about. AVP excess meaning free water excess states. Always it is better to begin with fluids which have zero free water, which is the 0.9% NS. The recently upcoming fluid is plasma-lite. Why plasma-lite is a preferred isoosmolar fluid is because of this low chloride content. Plasma-lite chloride content is too less and it is matching the chloride of what is actually present in our body, whereas the 0.9% NS chloride content is too high. So this will lead to a metabolic acidosis, which we call as a hyperchloremic metabolic acidosis. So such a chloride content might not be beneficial for routine maintenance, fluid maintenance, and therefore nowadays people are moving towards use of plasma-lite or the ideal maintenance fluid solutions. So this I have discussed now. So coming to the monitoring of a fluid on IV maintenance, the fluid balance is very important. So any child who is completely dependent on IV fluid for maintenance therapy, the fluid balance is very important. In fact, even we want to calculate the balance every quadrant, meaning 6 hours, so that you have to juggle your fluid maintenance volume based on your fluid balance. Second thing is serum electrolytes, at least 24 hourly. That is when you can detect whether your fluid is leading to hypernatremia or hyponatremia. So depending upon that, or also even your potassium, whether you are giving adequate maintenance potassium or not. So serum electrolytes, especially sodium and potassium, should be done at least 24 hourly. Weighing the child every 24 hours. Sometimes the subtle SIADH can be detected by mild increase in weight of the child. So before puffiness and everything happens. So the increase in weight of the child will give you an idea of the AVP excess state. Clinical evaluation, obviously we all will be doing. Neurological monitoring to identify the electrolyte disturbances early, suppose if you are not monitoring it very frequently, and glucose concentration. So a patient who is completely on IV maintenance fluid, we would request to do an RBS at least every 12 hourly, a random blood sugar at least 12 hourly, to check whether it is in the target range or not. So coming to the fluid overload, the fluid balance, why it is important to identify the fluid overload. Why fluid overload is important? Because fluid overload even more than 5%, meaning 50 ml per kg, can amount to a risk of mortality. So we have to limit the fluid overload to less than 5% in any child. In a child with normally functioning kidneys and normal physiology, the kidneys will excrete the fluid. But in a children who is having some sort of an organic problem or who is admitted with sickness, the ability of the kidney to excrete the unit due to the AVP excess will not be there, which will lead to a fluid overload. And fluid overload more than 5% has been documented in many studies to increase the mortality. Therefore, calculating the balance and identifying the fluid, it's very simple calculation. The total amount of fluid that you had given in minus your urine output, your drain output, everything divided by the ICU admission weight. So this will give you the fluid overload. If you multiply by 100, it gives the fluid overload percentage. So if it is more than 5%, then there is a risk of mortality. So 5 to 10%, usually we would like to start on diuretics and restrict the maintenance fluid. Suppose if it is more than 10% and we are not able to achieve it by restriction or diuretics, we would like to even to consider renal replacement therapy in very sick children. So coming to the potassium for maintenance fluid, usually it is added at 20 milliequivalent per liter. But suppose if the potassium level is too low, or at admission itself you have a hypokalemia, you can, or you expect the patient to be going into hypokalemia, you can add potassium up to 40 milliequivalent per liter to start with, and then it is titrated based on the serum potassium. So now coming into the management of sodium disturbances. So now we are going into specific management of sodium disturbances or disorders of sodium disturbances. So here the approach would be step 1 always is to assess the volume status and the urine output. Step 2, check the sodium level. Step 3, the osmolarity comes into play. Check the serum osmolarity, the urine osmolarity and the urine sodium, and based upon that you classify and then plan the management. We will go about. Usually the serum osmolarity always proportionates with the urine osmolarity. For example, you consider a state where the serum osmolarity is high due to dehydration, meaning there is more free water loss compared to the sodium loss. That is why your serum osmolarity is more, because serum osmolarity is totally dependent upon sodium. Even the formula itself is 2 into sodium plus potassium plus glucose by 18 plus BUN by 2.8. So this is the formula. The major determinant of serum osmolarity is your sodium, because glucose and urea are diffusible usually across the cell membrane. So if the serum osmolarity is more, meaning there is more free water loss, the urine osmolarity, how the body will compensate, there will be increase in AVP, there will be more free water absorption, thereby the excreted urine will be having lesser free water and urine osmolarity also goes up. So in a normal physiological response, the serum osmolarity and the urine osmolarity, they rise or they fall simultaneously. For example, if there is excess free water intake, there will be low osmolarity, AVP will go down, the urine will excrete more free water, and therefore the urinary osmolarity will also be low. The indirect marker of urinary osmolarity is your urine specific gravity. So either if the urine specific gravity is low and the serum osmolarity is low, or the serum osmolarity is high and the urine osmolarity is high, it indicates a normally functioning AVP axis or the renin-angiotensin axis. So these kinds of disorder are easy to manage. The problem is when this normal function is altered, or the situation where this normal function cannot be understood in a sick child. So that is when you have to go in a stepwise approach. So for example, if you have a high serum osmolarity, it could be either due to a high serum sodium or it could be due to a low serum sodium. So check the serum sodium levels. If the sodium level is very high, the volume status, if there is hypovolemia, you see the urine osmolarity and the urine output. If the urine output is low and your urine osmolarity is high, then it goes to a hypernatremic dehydration. Suppose if your urine osmolarity is low, but your urine output is very high, meaning for a routine response to hypovolemia and a high serum osmolarity, the AVP should be produced and increased free water absorption should take place. But your urine osmolarity is paradoxically high, meaning your AVP is not acting properly. So this will lead to an insipidus state. Either it could be a nephrogenic DA or a central DA. Suppose if in case of high serum sodium and there is hypervolemia and high urine output, which can happen only in one scenario where you are given excessive sodium and free water. So if you are given more sodium and free water and your serum osmolarity is high, so this can lead to excessive water as well as sodium loss. Here your urine osmolarity might be normal. The normal urine osmolarity ranges from 100 to 1200 in a healthy child. So this urine osmolarity will be normal or sometimes even might be higher in the higher range, and this is due to the supplementation of sodium and free water. Suppose if there is high serum osmolarity and your low sodium, it means like apart from sodium something else is contributing to the high osmolarity. So this condition we call it as pseudo hyponatremia, which we classically see in excessive triglycerides or excessive blood glucose level. But the current biochemical standards we don't see that much often because of a change in the measurement, the laboratory techniques of measurement of sodium, serum sodium. And the other possibility would be a translational hyponatremia, which we see in DKA, where we have to correct the sodium for the glucose, the routine formula where you have to add the sodium along with, you have to multiply it 2.8 into the current blood glucose minus 100. So the change in blood glucose more than 100, you multiply it by 2.8 and you add it to the serum sodium. So that is how you calculate the corrected sodium value. So these are spurious low sodium serum sodium values, but with high serum osmolarity. Now coming to the low serum osmolarity settings. So when the serum osmolarity is low, then you see in the serum sodium. So if there is a low serum sodium, look at the volume. If there are features of decreased circulating volume, meaning features of dehydration, then there are two possibilities. Either the dehydration is happening through the kidneys or the dehydration is happening elsewhere. So if it is an extra renal loss, usually the body's mechanism is to conserve the sodium. So therefore, if you check the urine sodium levels, the urine sodium will be less than 20 milliequivalent, and also because of decreased circulating volume, your AVP will be high. Therefore, your urine output will not be high. It will be normal or either low. So this is due to extra renal loss or a chronic diuretic abuse. Suppose if there is low serum sodium and dehydration features, but your urine sodium is very high and urine output is very high, which means that the sodium is losing through the kidneys, and the most commonest would be the renal salt wasting syndromes like cerebral salt wasting or an acute diuretic use or a congenital adrenal hyperplasia. Suppose if you see an increased circulating volume, for example, the child is edematous or the child is having features of fluid overload, pulmonary edema, then you have to do the urine sodium. If the urine sodium is less, this means like this is a state where there is an increased circulating volume and also a low serum sodium, but this low serum sodium doesn't amount to the total body sodium. It's not equal to low total body sodium. And that is why the body is conserving sodium. Usually when the sodium is low, but the circulating volume is very high, the aldosterone axis should have been blunted and the AVP axis should have been blunted. So here this is not happening paradoxically. So in this situation, the body is conserving sodium and also conserving more water. This happens in typically in cardiac failure, cirrhosis, and nephrotic syndrome, where the circulating volume or the effective circulating volume is very high. Suppose if the urine sodium is more than 20 milliequivalent per liter, which means like in a normal situation of increased circulating volume, the kidney is expelling sodium. So this happens in acute kidney injury. Suppose the child is fluid overloaded, you have a low serum sodium, and if your urine sodium is more than 20, you check the urea and creatinine. If there is any problem, then you are dealing with the acute kidney injury. Suppose if the circulating volume is normal, or if there is a mild weight gain, and your urine sodium is more than 20, and you see a urine osmolarity, if the urine osmolarity is more than 100, you are dealing with a SIADH case. So always you see the sodium level, check the serum osmolarity. So low sodium should always correspond to a low serum osmolarity. If the serum osmolarity is low, go into the circulating volume. If the circulating volume is normal, most likely possibility is SIADH. Confirm it by doing urine sodium. So in SIADH only in a normal circulating volume and hyponatremia, there will be sodium excretion. Normally in a child with hyponatremia and normovolemia, you expect sodium retention. But here the kidneys will excrete sodium, and your osmolarity because of sodium excretion is going to be more than 100 because of a limited free water excretion. So that is SIADH. Rule out SIADH, then you think of features. If in the history, if you get a feature of cardiac failure, cirrhosis, and nephrotic syndrome, well and good, you are dealing with a straightforward case. If you're not getting that, then you go for renal loss, whether it is extra renal loss or a renal loss of sodium and free water. So coming to the example cases, for example, this is the first case, a 2-month-old child who is presenting with loose stools for 3 days. The urine output has decreased. The child has extreme lethargy and poor feeding. So how will you approach? So this is an oligoanuric state. As we mentioned, discussed before, this child is having an oligoanuria and this child is having loose stools for 3 days. So from the history, we expect like this child is probably dehydrated, but there is a decrease in urine output. Whether this child is in the pre-renal phase or acute kidney injury is established, we don't know. Therefore, to begin with, we usually used to start this child with the isotonic maintenance. But since the dehydration is more prominent and the urine output decrease is very recent, we would like to start with 100 to 120% maintenance. And then we will start to look into the laboratory investigations. We would like to see. But suppose if this child has a presents to you with shock, give fluid bolus to correct the intravascular volume. That is completely a different topic. So coming to the reports, you are sending serum sodium, potassium, urine osmolarity, urine sodium, urea, and creatinine. So based on this reports, you are going to categorize whether there is a hyponatremia. So if there is a hyponatremia and dehydration, follow the routine protocol. If there is severe hyponatremia, meaning less than 120, you try to immediately correct with hypertonic saline because that will lead to CNS disturbances. So 1 ml per kg of 3% saline usually increases the sodium by 1 milliequivalent per liter. So you have to maintain at least a sodium of more than 125 milliequivalent per liter. So correct it with hypertonic saline, and then you follow your routine dehydration protocol. The commonest dehydration that we enter is the hyponatremic dehydration. The volume should be as per the dehydration protocol of WHO, but the fluid that you are going to give either should be a isolate or a plasmalite or should be NS. So that is the difference. So if the child is having hypernatremia, so you have to increase the maintenance dose from 120, at least you have to give at least from 120 to 150% of the holiday maintenance. But here the hypernatremia is due to excess free water loss as compared to the sodium loss. So here we are going to give the maintenance fluid with more free water. In normal saline, as we saw, the free water is 0. Here we have to give with more free water, and therefore the optional choice of fluid either should be N/2 saline or isolate P. In very young infants less than 3 months, we go for isolate P. In children more than 3 months or so, we go for N/2 saline, and it is always better to err in the towards the isotonic side. Therefore, N/2 saline can also be used as a universal maintenance fluid in such conditions. So if you go into specifics of calculations of hypernatremic dehydration, so here we calculate in ICU settings separately. What is the water need, what is the sodium need, what is the potassium need, and as well as how much duration that we are going to use to correct the hypernatremic dehydration. So the water need usually is the free water deficit plus maintenance minus the water that we had given through the bolus for correction of intravascular volume. The sodium deficit needs are the sodium deficit plus maintenance sodium, and potassium needs are the solute free deficit, which is equivalent to the maintenance sodium. So I will explain you how these things are done. So coming to the water needs, for example, you take a child with 10% dehydration and hypernatremia. So the maintenance fluid of this 10 kg child will be 1000 ml per day. For 2 days, the total maintenance based on holiday cigar is going to be 2000 ml. So coming to 15% dehydration, if the fluid deficit is 15%, meaning 15 into 100, which is 1500 ml approximately, the child is fluid deficit. Therefore, the total fluid rate for 2 days will be 3460 ml. You divide it by 48 hours, that will be equivalent to 73 ml per hour. So this is your rate of infusion of fluid, which is equivalent to 73 ml per hour. Now coming to the free water deficit, which is the sodium needs. For calculating the sodium needs, we are going to look into the free water deficit. The formula for calculating the free water deficit is 4 ml into body weight, that is 4 ml per kg, into the rise of sodium. For example, if the serum sodium is 168, you minus it by 145, which is the normal sodium, target sodium, which will be equivalent to 920 ml, meaning this 920 ml of loss of free water has resulted in increase in serum sodium from 145 milliequivalent to 168 milliequivalent. So we have to give this 920 ml in addition to our fluids that we are going to give. So out of this 920 ml, we have to find out how much electrolytes is also lost in this dehydration. So that we call it as fluid deficit containing electrolytes. So minus this 920 ml from the total fluid requirement. So that will be equivalent to your fluid deficit containing electrolyte. For example, if your free water deficit is 920 ml, the fluid containing deficit would be electrolyte deficit would be 580 ml. How this is obtained? You minus the 920 ml along with the free water deficit. The sodium deficit would be 8 to 10 milliequivalent of 100 ml of the free water deficit. So in this child, 580 ml is the fluid deficit containing electrolytes. So for every 100 ml, 8 milliequivalent of sodium is lost. Therefore, it is 8 to 10. So 10 into 5.8, which is 58 milliequivalents. Coming to the maintenance sodium, it is 3 milliequivalent per 100 ml, which is equivalent to 60 milliequivalent. So add the maintenance sodium along with the sodium deficit. So total sodium that you have to give in this patient is 118 milliequivalent. This is going to be given for the next 2 days. So depending upon that, you have to calculate like what is the sodium requirement. So 118 milliequivalent you are going to give in the fluid deficit of 1500 ml. So you divide it by 2, it will be equal to n by 2 saline. So whatever calculations that we do, eventually indirect way it is going to come closer to n by 2 saline. It might not be accurately to n by 2 saline, it is closer to n by 2 saline. That is why people recommend, like if there is dehydration, you give with an increased maintenance of 1.2 to 1.5 times and you use n by 2 saline. But that is not one thing where you have to stop. You have to repeat the sodium level every 6 hours. Thereby you have to titrate that based upon the serum sodium values. So suppose if your sodium fall is more than what you expected, usually the sodium fall should not be more than 12 milliequivalents per day or 0.5 milliequivalents per hour. If your sodium fall is more than expected, then you have to ideally reduce your free water. Therefore, reduce either the volume or change the fluid from n by 2 saline to to normal saline or something else, where you are reducing your free water. So that is how you have to titrate. So either you do with a strict calculation or you grossly go with n by 2 saline, but you check the serum sodium values frequently. Thereby you titrate your free water deficit until the patient can take enterally. Once the patient can take enterally, it is always preferred to correct hypernatremic dehydration based on enteral fluids. So you give enteral nutrition at a higher maintenance, or at 100% maintenance you give enteral feeds, but you add the free water alone as potable water to the like 4 ml per kg into the deficit. You have to add that potable water enterally. So that will the gut itself will regulate the fluid and electrolyte imbalance, and there will be a steady fall in serum sodium. So coming to the next patient, it's the LGBS. The serum sodium level is 125. The child is asymptomatic. You do a serum osmolarity which is low, which means it is a true hyponatremia. This child has received DNS in the evening rounds with 100% maintenance. So the next day morning, this child had suffered seizures, and we did a serum sodium level again, and this serum sodium was 122. Again, the volume status, everything is normal. The urine output was quite less. It is 0.8 ml per kg per hour, which is 750 ml, and the urinary sodium was 154 and a potassium of 84 milliequivalents. So this is a state that we call typically as SIADH. Here there is a normovolemia, there is a fall in sodium and a mild decrease in urine output with no features of edema. And when we weigh the child, this child weight slightly more and the urine output is less. And when we do a urine sodium, the urine sodium is high. So usually there is a sodium loss, but more than the sodium loss, there is more water retention or free water retention. So this is what we call it as a SIADH. The criteria of SIADH, everybody knows that, but the most important thing to diagnose is your high urine osmolarity and increased excretion of sodium. So any high volume state with hyponatremia and more urinary volume excretion and normal volume status, urinary sodium excretion and normal volume status, you think of SIADH. The most important treatment for SIADH would be your free water restriction. So restrict free water. Suppose if there is severe hyponatremia with symptoms, try to give 3% saline and push up the sodium levels. Coming to the third case, it's a case of pyogenic meningitis. Here you can note that there is a increased urine output and hypovolemia, and RBS, potassium and total calcium is normal. So any child with increased urine output, always rule out hypokalemia and hypocalcemia, because these two conditions can lead to a nephrogenic DI. So do a potassium and calcium. If it is normal, then you look at the serum sodium. If the serum sodium has serially fell from 142 to 135 to 131. So what is the diagnosis here? Here we are dealing with a state where there is a volume loss through the kidneys, and this volume loss is also leading to a salt loss. So both salt and volume is lost. So this is a state which we typically call as cerebral salt wasting. So here both salt as well as free water is lost, and the most important thing here is to replace the salt as well as the free water. So we typically replace the amount of urine output which is going out, we have to replace it. And again here, in order to decrease the free water restriction, we give something like ADH, desmopressin or vasopressin as an infusion. So the other typical, the difference is in SIADH there will be normovolemia, in cerebral salt wasting there will be hypovolemia. That is the most important difference. So coming to the potassium disturbances, we commonly, it's not as complicated as sodium disturbance, but potassium disturbances, any hypokalemia, you have to give potassium. Sodium, not all hyponatremia, you are going to give sodium. Potassium disturbances, hypokalemia, give potassium. Hyperkalemia, try to decrease potassium. So it is not related with your intravascular volume. Potassium disturbances, here your concentration is only on electrolytes, exclusively potassium. Whereas in sodium disturbance, you also have to take the volume into consideration. So coming to this case, a 3-year-old male child who had AGE and severe dehydration. This child became hypotonic after correction, but once you did the levels, the urine output was normal and the serum sodium was 130, which is mildly hyponatremic due to the hypotonic fluid, and serum potassium was 2.3, urea creatinine is normal. So patient was given correction. The routine potassium correction that we give is 0.5 milliequivalent per kg per hour. How we are going to give? We prepare a stock solution of 10 ml of KCl in 90 ml of NS or dextrose, and we are going to infuse it at the rate of 1.5 ml per kg per hour. This will be equivalent to or correspond to a correction of 0.5 milliequivalent per kg per hour. The correction has to be given until the T waves appear. So after that, the infusion was stopped. The repeat potassium after 8 hours also revealed low serum potassium. Again, the serum potassium was only 2.2. So during this condition, we have to consider ongoing losses. Therefore, in the treatment of hypokalemia, it is not only the correction of potassium, it is also the replacement of the loss of potassium and to the maintenance potassium, the routine maintenance potassium that we give. So here only correcting the immediate serum potassium will not correct your hypokalemia. You have to increase your maintenance potassium also from the baseline. At the same time, you have to replace the ongoing losses. For example, if the ongoing losses is through stools, for every stool you have to replace it with ORS or a ringal lactate or some kind of a potassium containing fluid. If the replacement is through the kidneys, you are going to find out why there is a replacement through the kidneys. Usually the loss of potassium in kidneys occurs in a hyperaldosteronic state. There won't be a loss of potassium from the kidneys without a change in aldosterone. So usually it occurs in a hyperaldosteronic state. So during such condition, you go ahead to find the reason for the hyperaldosteronic state or whether there is a use of diuretic abuse. So find the etiology and then stop the etiology. So you have to correct the etiology, replace whatever is being lost, and also ensure that there is a normal maintenance and the ongoing replacement should continue for hypokalemia. So other factors which influence the serum potassium, as I said before, is magnesium. Magnesium correction will lead to refractory hypokalemia no matter whatever you do. So if your hypokalemia is not corrected, look into the magnesium level. So hypomagnesemia needs to be corrected along with hypokalemia, because if there is hypomagnesemia, the renal potassium loss will be more, and that will lead to refractory hypokalemia. The other thing is metabolic alkalosis. So when there is metabolic alkalosis, again there will be shift of potassium into the cells. Therefore, the serum potassium will be low, even though the total body potassium will be very high. So here you need not increase the maintenance potassium. You can just give the potassium to maintain the normal potassium levels, but you have to treat for metabolic alkalosis. So correct the metabolic alkalosis. The other treatable factors would be beta agonist use and insulin, where we commonly see hypokalemia due to spurious reasons. Coming to hyperkalemia, the one important message that I would like to say about hyperkalemia is do not ignore any high value of potassium as spurious value or due to squeeze sample, because you might not know what is the condition. So always when there is a high potassium value, try to corroborate at least by doing an ECG and look into the clinical status. So see whether there is any oligoanuria, whether there is any low urine output. Check the last urea and creatinine. Check what is the current clinical situation of the child, whether the child is having dehydration or whether this child is in a fluid overload state, or any other medicines that has been given to increase the potassium value, or the child is having an acidotic breathing. So kindly check your clinical status of the child, and also do an ECG. Corroborate your potassium value with the ECG. If the ECG is normal, then probably it could be spurious, and therefore you can ask for a repeat potassium. But if your ECG is high, then you have to immediately go for the treatment for hyperkalemia. Therefore, do not ignore any hyperkalemia as a spurious value. Go into the history, clinical examination, and also find out any precipitating factors for hyperkalemia in this particular child. Coming to the calcium disturbances, the most important thing I would like to stress in calcium disturbance is to differentiate between a total hypocalcemia and a ionized hypocalcemia. For example, if you take a nephrotic child, a 7-year-old child with a nephrotic syndrome, the serum sodium is 135, calcium is 7. So upfront you see that this child is having a hypocalcemia. Could be this child would be having a true hypocalcemia. We don't know, because child would be taking steroids for a longer time. There is a possibility of true hypocalcemia, but it can also be spurious. Therefore, you have to always correlate with the albumin. So check the albumin, calculate the corrected calcium, which is something like 4 minus the serum albumin, that you are going to multiply it by 0.8. So 0.8 into plus into 4 minus the serum albumin. So thus that value you add it to the serum calcium. So and check whether this total serum calcium is coming to more than 8.5 milligram percentage. Suppose if you are not able to find an albumin level, if you cannot do an albumin, always check for ionized calcium. So if the ionized calcium is low, then you treat. If the ionized calcium is normal, you need not treat with calcium supplements, even though there is a total hypocalcemia. Again, in a 4-year-old child admitted with this is another case of ionized hypocalcemia, admitted with pneumonia. When you do a ionized calcium, it is 0.5, but when you do a serum calcium, it is around 8 to 8.5. So there are situations where even spurious ionized calciumia or a relative ionized calciumia can happen. That happens when there is a metabolic respiratory alkalosis or a metabolic alkalosis. So when there is an alkalosis, your ionized calcium levels can go down. Here in this state, if the child is symptomatic, we would be giving calcium supplements. Symptomatic meaning either if the child is in shock or if this child is having tetany. So there immediately we have to increase the serum ionized calcium levels. Otherwise, this is just a translocational phenomena. So when you treat the metabolic or respiratory alkalosis, your ionized calcium will come back to normalcy. So these are two conditions in calcium that I would like: when to give calcium, when not to give calcium. You have to give calcium only when there is a true ionized hypocalcemia, meaning when the calcium levels are ionized calcium levels are low, less than 1, and also in the blood gas status there is no metabolic alkalosis and there is no hypoalbuminemia. This is the state where you have to immediately give calcium infusions. So calculate the corrected calcium, ensure that acidosis alkalosis can change your ionized hypocalcemia, and also find out the precipitating factor if there is a true hypocalcemia, because unless you treat the precipitating factor like vitamin D deficiency or a nutritional hypocalcemia, this thing will not be corrected. Therefore, you have to ensure adding maintenance calcium also. And one more important stress I would like to do is always do a phosphorus along with calcium. So if you have a hypocalcemia, but it is associated with hyperphosphatemia, even this is another condition where you should not give calcium, because when you give calcium in a child with hyperphosphatemia, it would lead to calcium precipitation. So a child with high phosphate along with low calcium, a child with low ionized calcium but having alkalosis, a child with low total calcium but having hypoalbuminemia and the corrected calcium levels are normal, do not give any calcium infusions. Therefore, calcium, the most important thing is do not treat the value. Try to find the precipitating factors, adjust the value for all these correctable factors, and then you treat calcium. Thank you. So Dr. Senthil Ganesh sir has asked a question. Kindly explain the difference between osmolarity and tonicity. So osmolarity means the number of solutes that is present in the solution. It is not related to the intravascular circulating wall. It is not related anywhere to the blood. So it is the that is exterior to the body. So here you have a solution with more solutes as compared to water. We call that this solution is hyperosmolar. The number of solutes to water is what is called as a osmolarity. Tonicity is the amount of pressure that the solution exerts on a semi-permeable membrane. So If you have a semi-permeable membrane, you have a solute solution, and if there is a solute which can permeate through the semi-permeable membrane, it does not exert any pressure on the semi-permeable membrane. The pressure is exerted by the non-permeable solutes. So that is what determines your tonicity. So that is why we say inside the blood, the sodium determines the tonicity, because that is the predominant electrolyte in the extracellular fluid. Whereas when you take as a solution, any solution can be hyperosmolar. So all hyperosmolar solution might not be hypertonic, but definitely all hypertonic solution are hyperosmolar. For example, 3% saline, it is a hypertonic solution, and definitely it is a hyperosmolar solution, because everything is sodium and the sodium cannot permeate through the semi-permeable membrane. So that is a hypertonic solution as well as hyperosmolar solution. But your 0.9 DNS, even though it is a hyperosmolar solution, once given into the body, the dextrose permeates through the semi-permeable membrane. Therefore, it does not exert any pressure on the semi-permeable membrane. It is a sodium, and that sodium is isotonicity, which is equivalent to that of a serum sodium. So that is why this is a isotonic solution. If there is no more questions, then we can wind up the chat. Thank you. Thank you.